Okay, lecture 4, CBC and the CBC and the RBC indices. Okay, the CBC. CBC is one of the most commonly ordered tests. And one of the reasons why it's the most commonly ordered test is that when you get a printout or when you run a CBC, even just the automated portion, the complete CBC actually includes the manual differential, or you can have an automated differential, which the machine can do, or if you get flags, then you're prompted to do a manual differential. But the CBC, once you get all your information, you can get a whole bunch of information as to what's going on with the patient by just, and I'm going to teach you how to determine what's going on with the patient by just looking at certain, the different parameters, okay? The complete blood count quantifies the cellular elements in the blood, and the cellular elements include the WBCs, which includes the neutrophils, the monocytes, and the lymphocytes, and the platelets, the red blood cells, okay? So it quantifies those, it counts those. And then for the indices, and from lecture 1, you know, I told you which ones are the calculated parameters and which ones were the calculated parameters. And I'm going to go over those later in this lecture. Okay, the white blood cell count is the count of the actual number of white blood cells per volume of blood. And like I said, it includes the neutrophils, the lymphocytes, and the monocytes. And both increases and decreases can be significant, including the platelets. So who can remember what the term is for an elevated white blood cell count? Elevated.
Higher than 11 is bad?
No, there's a term.
Oh.
Yeah, higher than 11 is bad. It is. So there's a term for.
Is it
leukocytosis?
Correct, leukocytosis. What about a decrease? White blood cell.
Leukopenia?
Leukopenia, correct. Okay.
cytopenia?
Cytopenia means
Leukopenia.
right. Anything penia. You see penia, like thrombocytopenia. What is thrombocytopenia? Low.
Low
Thrombocytes?
Correct. Low thrombocytes, or what are thrombocytes?
platelets.
Platelets. Okay. Okay, so white blood cell count. Now, okay, the WBC, you can tell by looking at the WBC a lot of things. If you have white count, obviously if you have, you know, you're gonna look at abnormal white count. So whatever it is, 4 to 10, whatever that's normal. What's important is how high, what does a high white count mean? Or what does a low white count mean? Okay. If you have a white count, 15,000, 20,000, maybe up to 30,000, okay, you have possibly a bacterial infection. Okay, 10,000, 15, 20, maybe up to 30,000. You probably have a bacterial infection. Okay, there's other things too to look for a bacterial infection. So when I get into the myeloid series, and I'm getting ahead of myself, the maturation sequence of the myeloid series, I'm getting ahead of myself, is mature neutrophil. I already mentioned neutrophil, correct? The stage before the cell before a neutrophil, it's called a band, okay? And a cell before that is called a metamyelocyte. So the maturation sequence, when you remember when I talked about red blood cells, and they're released early due to increased demand. On the red blood cells, what happens to the bone marrow when there's increased demand? What do you see more? What is released into the peripheral blood due to increased need of red blood cells? What do you see that's increased?
Nucleated cells.
Well, that's, you could see nucleated cells, nucleated red blood cells, but a little bit more mature than that.
Reticulocyte.
Reticulocytes. Okay, so you'll see reticulocytes. So if you go from mature red blood cell, and the stage before that is reticulocytes, and the stage before that is nucleated red blood cells. You can kind of like call that a left shift, but usually a left shift refers to white blood cells. So when on the white blood cell side, the mature cell is a neutrophil. Now, you know what a neutrophil is from the differential. Well, the maturation stage, the cell before neutrophil is called a band. The neutrophil has filaments that separate lobes. Well, that filament is not completely developed, and the filament is actually fat, making the cell look like the nucleus look like a band. Okay, I'll get more into that in the myeloid series. That's called a left shift. So you all would also see bands in the presence of an infection. So you have an elevated white count, like I said, 15, 20, up to 30,000. Okay, you need to suspect a bacterial infection. If you get white blood cell counts 50, 70, 90,000, definitely 100,000. Now you're talking anemia, leukemia. Okay, so those numbers are definitely numbers that you don't want to see. And then on the smear, you're going to see immature forms. Like now you're looking at metamyelocytes, promyelocytes, blasts. The really immature. On the myeloid side, I am going to require that you know the different types of cells, the blast, the myelocyte, the promyelocyte, metamyelocyte, all of those. Okay, but I'm not going to have you do the precursors of the red blood cell. The myeloid, the different on the myeloid series, I want you to know all the cells of the maturation sequence of the myelocytic series. So when you have a leukemia, you can get like as early as metamyelocyte, myelocyte, promyelocyte, etc. So that's when you have counts of 50, 70, of greater than 50,000 up to 100,000, can be really, really high. And on the smear, when you look at the smear, all you see are nothing but cells. Okay, white blood cells. Okay, normally you would see the majority of what you see on a field, microscopic field, is the majority is red blood cells. But when you have leukemia, you take a look at it, and boom, you see, oh my God, all these white blood cells. Now, when you do your WBC identification, Xavier has some. I gave him some leukemia slides that you're going to have to identify different cells, and that's he has those. So you'll see what a leukemia slide looks like. So now you know what an infection looks like: 15, 20, up to 30,000 white blood cell count. And then leukemia is greater than 50,000 up to 100,000, maybe more. Okay, so that's leukemia. Now, how can you tell if you have a viral infection? Okay, so now you know bacterial, now you know leukemia. How do you know you have a viral infection? Well, if you have a viral infection, your white count is actually low. You're talking about 2,000, 3,000. So normal is about what, 4 to 10? But if you have a white blood cell count of 2,000 or 3,000, or as low as 1, but usually it's 2 or 3,000, then you're going to probably suspect a viral infection. And also too, your lymphocyte. Okay, so you know your normal values for the differential count, right? It's like 60. So neutrophils is like in the 60s, lymphocytes is like what, in the 30s, 40s, and monocytes is lower than that, and then followed by eosinophils and basophils, right? So your normal distribution, the most is neutrophils, followed by lymphocytes, followed by monocytes, then eos and basophils, correct? Am I correct on that?
Yes.
You guys memorize your normal values, right?
Yes.
Okay. In a viral infection, okay, normal distribution is the most is neutrophils, followed by lymphocytes. In a viral infection, you have what's called a flip. The lymphocytes is now the most numerous, and it's more than the neutrophils. So you have more lymphocytes than neutrophils. You can have up to 50 to 60% neutrophils, and then followed by a smaller percentage of, 50 to 60% lymphocytes, 50 to 60%, maybe 70% lymphocytes, followed by neutrophils, and it's in a lower percentage. So when you have more neutrophils, that's why you got to be careful when you do your differentials. If your lymphocytes are more than your neutrophils, then you have a possible viral infection. And then if you look at the total white count, if the total white count is low, maybe like 2,000 or 3,000, then you probably have a viral infection. Another thing to look for in that you have a viral infection, and I'm going to get into this when I talk about lymphocytes. I'm going to talk pretty extensively about the difference between lymphocytes and monocytes. But if you see things like what's called an atypical lymphocyte, then that's definitely a viral infection. That's actually, if you see atypical lymphocytes, that's infectious mononucleosis. I'm sure you've heard of that before. Okay, so low WBC count is viral infection. Elevated WBC count, but not too elevated, like 15, 20 up to 30,000 is bacterial infection. And then 50,000 or more up to 100,000 or more is probably leukemia. Okay, so depending on what you see on the CBC printout, take a look at your white count and you can see what's going on. A slight increase on the WBCs then that's okay. It's not illegal. You can't say that, oh, you got a bacterial infection. It's okay to be slightly above the normal range of a WBC. But if you get like 15, 20 up to 30,000, then that's pretty significant enough for the doctor to worry that you probably have a bacterial infection. Okay, the WBC differential, as you know, always has to add up because it's a percentage and it's a relative count. Because it's a percentage, the total has to add up to 100. If it's automated versus manual, remember automated is the values are decimal format, and manual differential is what you actually count. You're going to count 100 cells, and you will actually do that in the laboratory where you do a differential. I think it's the last activity that you'll be doing in December. You'll be expected to do about 10 differentials. Okay, it looks like the type of WBCs, depending on the instrument. Most instruments will do a 5-part differential where it'll take a look at neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And then other instruments for the smaller laboratories, the doctor will be satisfied with just getting a 3-part differential, which is the granulocytes, lymphocytes, and monocytes. Okay. The RBC count, okay, is a count of the actual number of red blood cells per volume of blood. Both increases and decreases can point to abnormal conditions. So in the last lecture, I talked about low RBC counts, and you don't call it erythropenia. I don't think that's even a low term. When you have low RBC parameters, which are the RBCs, hemoglobin, and hematocrit, and also to your RBC indices, it's not erythropenia. It's called anemia. Okay, the simple term is just anemia. Now you can have elevated RBC counts, and there's conditions where you have elevated RBC counts, and I'll talk about that later. It's called polycythemia. Polycythemia. That's where you have, and I talk about that in the myeloproliferative disorders. You get polycythemia vera, polycythemia rubra vera, but that's polycythemia where you have an elevated RBC count. For hemoglobin, you know how hemoglobin is measured. You lyse the red blood cells, and then the solution goes into the WBC bath, and the hemoglobin that's released from the lysed red blood cells is measured as hemoglobin 540 nanometers, using the 540 nanometers. 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 540 built-in spectrophotometer on the analyzer. Measures the amount of oxygen carrying protein in the blood. Hematocrit. Okay, hematocrit is the proportion of blood that consists of the packed red blood cell volume. So you take a sample of blood in a tube and you spin it down by centrifugation, right? And what happens is the red blood cells will go to the bottom, and that's called the packed red blood cells. It's packed down to the bottom. And if you measure the amount of packed red blood cells in proportion to the total amount of blood that's there, that percentage is called the hematocrit. Okay, so this, say for example, from the top of this tube, and this is the top of your sample, down here, that's 100% of your blood. After centrifugation, your cells are packed right here. This is the PCV, is packed cell volume, and that's equal to about 40%, 46% of the total volume. Okay, so it's a percentage by volume, the packed red blood cells. The rule of threes, I know I mentioned rule of threes earlier, or even during the break. So take a look at your CBC. You're going to be, like I said, you're going to train your eyes to look at certain things on the CBC. Like one of the questions on on your homework was, what's wrong with this CBC? You need to be able to identify whether or not the CBC that you're handed is reportable or not. And one of the things you look at is the rule of threes. The hemoglobin should be equal to 3 times the hematocrit. It should be equal to 3 times the hemoglobin. So 13 times 3 is 39, but then there's leeway. It's 39 plus or minus about 3. But if you get a hemoglobin of 13 and you're getting like 45 or 50, then the rule of threes is a failure. Okay, the rule of threes failed, and your MCHC should also fail as well. It's probably not between 32 and 36. So if your rule of threes failed, right away look at your MCHC. Oh yeah, that's right. It confirms it's a true failure. Your MCHC is probably like around 45 or 50, something outlandish, but it's definitely outside between 32 and 36. So one thing to look at is your rule of threes, hemoglobin, hematocrit. That's one of the easiest checks. Hemoglobin times 3 is equal to hematocrit. Okay, rule of threes. Packed cell volume. So here, what would be the approximate hemoglobin? If that's your
15.
hematocrit,
15.
what would your approximate hemoglobin be?
Approximately 15.
Approximately 15 is correct. Okay, so if you're given the hematocrit, then you can probably say on the CBC, on the printout, it should be about 15, 14.9, 14.8, so or whatever, but it's going to be approximately. Remember, it's plus or minus 3. It's not exact. Hematocrit, it measures the percentage of red blood cells in a given volume. I just went over that. Okay, MCV. I've been talking about MCV. It's the measurement of the average size of the red blood cells. So MCV is the size of the red blood cells. Now, what is the normal value for MCV? It's like what? 80 to 100?
Is it femtoliters?
Yeah. What is the normal value for MCV?
80 to 100.
80 to 100. Okay, so anything, if I give you an MCV about 90, so you got normal red blood cells. If you're looking at your CBC printout and the MCV is about 50, 55, or 60, what is the term for describing the cells?
Microcytic.
Microcytic. And if it's 112, 115, what was that?
Microcytic.
Macrocytic. Now, if you see
Macro.
pardon me? if you see an MCV that is about 130, 140, that's impossible. Okay. There's no such thing as a red blood cell that humongous. I mean, there's no such thing as a humongousyte. Okay. If you get an MCV, I mean, it's got to be within reason. If you get an MCV that's incredibly large, like 130, 140, 150, okay, that's possible. Okay, but it's an artifact, and it's for you to determine what kind of artifact it is. Okay, so the machine is will measure whatever you feed into the machine, and it's going to give you what it reads. If it tells you that it's reading something that is giving you an MCV that is 150 or 160, that's impossible for a red blood cell to be. So one of the things that you can look at, or one of a couple possibilities, are if you have cold agglutinins. Cold agglutinins is where your RBCs will be stuck together. When your RBCs are stuck together and it goes through the flow cell, remember the flow cell in the first lecture? If you get RBCs that are stuck together, as you'll see in cold agglutinins, then you're going to see MCVs that are outlandish, 150, 160. Okay, that's, like I said, it's physically impossible for a red blood cell to be. Another thing that you could see is that platelets have a tendency to stick together as well. So sticky cells that forms globs that gets fed through the flow cell, your instrument is going to count it as something with an MCV in the 150s or 160s. Your MCHC is also going to be out of whack too. So you see an incredibly abnormal MCV, and again, you're going to take a look at your MCHC, see if it's within reason. Both of them will not be normal. So, and I'll show you how to determine what exactly the problem is. One of them is platelet clumping, which you'll see, and the other one, like I said, is cold agglutinins. I'll get into that in lecture 10 because there's artifacts I want you to know how to detect. But like what you said, in MCV, normal is 80 to 110, less than is microcytic cells, greater than that, outside of the range, is our macrocytes. Now, on tomorrow's quiz, you're going to be getting a CBC that's unflagged. Okay, so I told you to memorize the normal values. If you see the CBC and you look at the value, what you're going to do is you're going to determine, is that value within the normal range that you memorized. If it's below the normal range, you're going to put an L. If it's above that normal range, then you're going to put an H for high. If it's within the normal range, you don't do anything. Okay, you're only going to flag those values that are outside, on the low side or on the high side of the normal range. Okay, so that you're going to get that on your quiz tomorrow. You'll probably get that on your exam too, because I really want you to know what your normal values are because you need to know when you look at a CBC, if the values are low. Now the instrument, when you're in a real laboratory, it's going to flag for you anyway. You're going to get your L's and your H's. Okay, that's good. But then what I want you to know is to start to being comfortable with the normal ranges. Okay, so MCV is the size of the red blood cells, macrocytic cells and microcytic cells. But you also have to be aware of, you're going to get macrocytic cells that are not reasonable. Like I said, MCVs in the 150s. Okay. Okay, MCH and MCHC. Okay, MCH. Okay, it's a little confusing. MCH is the amount of oxygen containing hemoglobin. Okay, and then MCHC is the amount average concentration of hemoglobin inside the cell. So MCHC is the total amount of hemoglobin, whether or not it's oxygen, it contains oxygen or not. But the MCH only is a measurement of the oxygen carrying hemoglobin. Okay, so you know, on hemoglobin, it's either, remember, going to the tissues, it has oxygen, and on the way back to the lungs, it doesn't have oxygen. Okay, so there are two types of hemoglobin. Well, the MCHC is a measurement of those two types of hemoglobin, whether or not it's oxygen carrying or not. So MCHC is a total amount of hemoglobin. MCH is a measurement only of the oxygen carrying hemoglobin, on the oxygen hemoglobin on the way to the tissues. Okay, so that's the difference. You follow me on that one? That one for me was a little hard to understand when I was in training, but I just want to make sure that you understand the difference. MCH is oxygen carrying hemoglobin, and MCHC is a total hemoglobin, whether it's oxygenated or not. Okay, RDW, or red cell distribution width, is a calculation made by the analyzer. Remember the diagram, I showed you two diagrams where you had spikes, tall, small, average, a lot of variation and not so much. Okay, so there was a lot of variation in size, correct? And then the one below, there were a lot more spikes, but there was not that much variation. There was still a little bit of variation, but the difference between the spikes was really not that much. So the variation was low. RDW is a measurement of variation in the size of the red blood cells. If you have a high variation in size, what is the term for variation in size? There's a term for that. Anybody remember?
Oiko.
Any cytosis?
Cytosis.
Anisocytosis. I admire your courage, Liz.
No worries, thank you.
Aniso. So one way, okay, so here's a trick. Aniso, S on aniso, size, okay? Aniso S, and then poikilocytosis, P for shape. If you see a lot of shapes, P for shape, okay? So if you see a lot of different shapes, then that means there's a lot of poik or poikilocytosis. If you see a lot of variation in size, that's aniso. So a high RDW is a measurement of a high of a specimen that has a high amount of variation in the size of the red blood cells. Okay, high aniso, high variation in size, high RDW. The anemia that I was talking about in the last lecture that has a high RDW, remember which anemia that was? You guys already forgot the anemia I was talking about? Okay, begins with an I.
Iron deficiency.
Iron
and-
Oh,
deficiency.
you guys were paying attention. I knew it.
I was scared.
You were scared. Don't be afraid. I'm not even in biting distance to or throwing object distance of you guys. So don't be afraid. Iron deficiency anemia. Like I said, that's like one of my favorite anemias. Iron deficiency anemia is because it's easy to pick out. It has a super high RDW. And also too, when you look at the smear, it has a lot of poik. So you see all this poik, you're going to see target cells, you're going to see schistocytes, you're going to see ovalocytes, you're going to see macrocytes, and you're going to see microcytes. But it's classified, the classification of iron deficiency anemia is hypochromic microcytic anemia. So the MCV is going to be low. It's a hypomicro. It's a hypomicro, meaning that your MCV is going to probably be in the 50s or 60s. And MCH is also going to be low. But your so this is one anemia where everything is low except for RDW. Your RDW is going to be really, really high. So this is one anemia where the parameters is high. Everything else on iron deficiency anemia is low. Your reds, your hemoglobin, hematocrit, and your RBC indices. Okay, everything is low on the red side. So you definitely have anemia, but when you see that you have a high RDW, okay, then that's iron deficiency anemia. And then when you look at this, when you look at your smear and you see a lot of white space, meaning that you don't see too many red cells, PC, a lot of white space, but it's all there and they're all different. You see a lot of POIC, then that's iron deficiency anemia. Like I said, for me, it's one of the easier anemias to identify.
So why do you see a lot of the RDW? Your bone marrow is compensating?
Remember, it's inefficient erythropoiesis.
Oh,
So because of that inefficient erythropoiesis, it's going to be kicking out all these these weird red blood cells.
okay.
Okay, and that's because what prompted that was the low iron.
Okay.
So the low iron is going to result in ineffective erythropoiesis. So your bone marrow's, garbage in, garbage out. So you're going to get all this POIC getting kicked out of the bone marrow. That's
Okay.
why. That's why.
Thank you.
That's a good question. Okay. As you can see, nothing is red on this slide, but it's meant to illustrate how the hematocrit changes from birth. So newborn hematocrit is 55 to 68%. A week later, then it's going to drop 47, 65. A month later, it's going to drop to 37 to 49. 3 months later, it's going to drop to 30 to 36%. This is hematocrit. And at 1 year of age, it's going to stabilize to 29 to 41%. And similarly, at 10 years of age, it's going to be 36 to 40%. Normal value for males is 40 to 54%, and females' normal range is a little bit lower, 37 to 47%. So with age from birth, your hemoglobin concentration or your red cell concentration changes as you get older, and then it stabilizes at a year, 1 year, 10 years, and into adulthood. Okay, so that's what this slide is meant to illustrate. Okay, your red cell indicators, RBC, hemoglobin, and hematocrit. Increased red cells, like I mentioned earlier, there are conditions, primary polycythemia. That means you're producing more red cells, and that's actually a condition, and I'll talk more about that in the last hematology lecture, which is in the myeloproliferative disorders. Or you can have secondary polycythemia. And secondary polycythemia is actually a false polycythemia, and it's caused by reduced fluid intake. So if you don't drink enough water, then you don't have any fluid. So therefore, your RBCs will appear to be increased because you have excess fluid or excess fluid loss. So reduced fluid intake or excess fluid loss will make it appear that your red cell, the amount of red cells relatively will look like it's increased. Okay, that's secondary polycythemia. And then you can have congenital or acquired heart and lung disease. Those are pathologic conditions that will, it could be excess fluid loss can give you a false increase in RBC count. Your acquired heart and lung disease, high altitude, heavy smoking, tumors, renal carcinoma, or a liver tumor or a hepatoma. Decreased RBCs, those are your anemias. Your megaloblastic anemia, that's where you have megalo meaning large. So you have large red blood cells. Okay, you get oval macrocytes. I'll talk about that when I talk about the megaloblastic anemias. The main ones are folate or folic acid or B12 deficiency. Iron deficiency, you can have megaloblastic anemia, but you see the whole spectrum, but you can get large RBCs in iron deficiency anemia, sickle cell anemia, and other hemoglobinopathies, acute or chronic blood loss, sideroblastic anemia, hemolysis, anemia due to chronic disease, dilution, alcohol, and drugs. There's not much red in here because I'm going to be talking about these conditions specifically in upcoming lectures. Okay. All right, the RBC indices. These are the main ones. You're going to be getting, I think, you're going to be getting an exercise where you're going to be calculating RBC indices, you'll get the formulas, and you have what you have to do is you have to calculate the missing parameter. So the RBC indices are MCV, MCH, MCHC, and RDW. RDW, there's no calculation for that. That's something that the instrument will actually measure. So the MCV, that's the formula. Make sure you know the formula. It's hematocrit times 10 divided by RBCs, okay? Normal range is 80 to 100. Anything below 80 is microcytic. Anything over 100 is macrocytic. But make sure you know the formula. I think I'll still give you the formula sheet, what MCV, MCH, and MCHC are. MCH is the mean corpuscular hemoglobin. And the formula is hemoglobin times 10 divided by RBCs. The normal range is 27 to 34. MCHC, remember, it has to be 32 to 36. Anything greater than or outside this range is not normal. Okay, so make sure you train your eyes. That'll be one of the first things that you see. And MCHC is equal to hemoglobin times 100 divided by hematocrit. Both the MCH and MCHC are used to determine the content of hemoglobin in the red blood cell. Okay, MCHC is the total hemoglobin, whether it's oxygenated or not, and the MCH is oxygenated hemoglobin. RDW is red cell distribution width, RBC distribution width, and it's a measure of anisocytosis, the amount of aniso or variation in size. Normal is 11.5 to 14.5. Okay. Anything greater than 14.5 is reportable as either 1+, 2+, etc. So if I gave you an RDW, make sure you know the range for an RDW. If I gave you one of 16 point whatever, then make sure you put an H over by it. Usually RDW doesn't fall on the low end. Usually if it's an abnormal RDW, it's outside of the range, it's usually high. Okay, the types of anemia, you can have a normochromic normocytic. You can't tell by looking at the smear because everything looks normal. Normochromic refers to the central pallor of the cell. You can have a normal central pallor, it's normochromic. Normocytic refers to the size. So you have normal central pallor and you have normal size. So you look at this smear and you can say, well, this looks like a normal red blood cell, but it can happen during these conditions: sudden blood loss, like a gunshot wound, prosthetic heart valve, the red blood cells look normal, a tumor, long-term disease, and aplastic anemia. There's a specific lecture on aplastic anemia. Aplastic anemia is where the factory just shuts down. Okay, your bone marrow is not producing anything. That's what aplastic anemia is. But interesting, the red blood cells are normochromic and normocytic. Hypochromic microcytic, we already went over one main one, and that's iron deficiency anemia. A lot of POIC, remember, a lot of POIC and a very high RDW. Those are the two hallmark indicators for iron deficiency anemia. It's classified. I'm going to ask you what anemia is. Okay, I'm going to give you a smear. I'll ask you, what anemia is this that you think it is? And you'll say iron deficiency anemia. And then I'll ask you, what type of anemia is this? Your answer will be hypochromic microcytic. The type is hypochromic microcytic. So I'm going to show you a smear where you can see oval macrocytes and big cells. I'm going to ask you what anemia is this, and you're going to say it's B12 folate deficiency. And I'll ask you what type of anemia this is, and you're going to say megaloblastic anemia. Okay. Another type of hypochromic microcytic anemia is found in lead poisoning. Lead poisoning, you'll see what's called basophilic stippling. I don't know if you saw basophilic stippling. A basophilic stippling is where you have red blood cells and it looks like it has freckles. Okay. Did I show you basophilic stippling on day one? You remember? No? Okay. I'll make sure I'll go over that. Thalassemia, T for target cells. Okay, just remember that. Significant RBC morphology are target cells. So T for target cells is thalassemia. Thalassemia is another hypochromic microcytic anemia. The two hypochromic microcytic anemias, the main ones, are thalassemia and iron deficiency anemia. Those are the two main ones. Those are the two anemias that you should have in your mind when I talk hyperchromic microcytic, hypomicro. I said, well, give me a hypomicrocytic anemia. And you're gonna say, oh, iron deficiency anemia. Okay, give me another one. Then you'll tell me thalassemia. In thalassemia, the predominant cell type is our target cells. You get microcytic cell red blood cells. The difference between iron deficiency anemia and thalassemia is in the RDW. RDW is high in thalassemia, but it's not as high as iron deficiency anemia. Okay, that's how you can tell the target cells, because you'll also see target cells in iron deficiency anemia, but you'll see more target cells in thalassemia. Okay, but the RDW is high, but not as high as iron deficiency anemia. Okay, so that's plenty on hypochromic microcytic anemia. Normochromic microcytic means that it has a normal central pallor, but the cells are small. And this is seen in deficiency of erythropoietin and kidney failure. And then you got normochromic macrocytic anemia. Okay, so you have normal central pallor, but you have large red blood cells. Usually they're oval macrocytes. Normal central pallor, but you're going to have big cells. Okay, so in the megaloblastic anemias, which is what I'm just talking about, the B12 folate deficiencies of the macrocytic cells, your MCHC is going to be riding on the upper end of 36. Okay, the MCHC on the megaloblastic anemias is going to be approximately 36 or thereabouts. If it's 37, don't worry about it. That's legal. And you look at the smear, you see big cells. Okay, that's probably why. So folic acid deficiency, folate or folic acid deficiency, you're gonna have borderline high MCHC. You're gonna see oval macrocytes. Okay, high MCV. Vitamin B12 deficiency, you will also see borderline high MCHC. You'll also see oval macrocytes and a high MCV. And that's it for this lecture. Do you have any questions?
Professor, I do. Can you go back to the picture? I want to know how you were able to determine how much it was. It was the vial, that one.
This one?
Yes. How do you look at it?
Okay, so what I see is they have microhematocrit tubes. This is already spun down. The
Mhm.
red blood cells have been spun down, and what you see, PCV is the packed cell volume. See, all the cells have been centrifuged down to the bottom here, right? Okay.
Yeah.
So what you do is you measure this in millimeters. Okay, you also measure the total. Okay, for simplification, let's say this is 1.0 whatever centimeter, and this is 0.46 centimeters. Okay,
Yeah.
so 0.46 is the amount of the packed cells in this whole amount of blood, in this sample of blood. Okay, you spin
Yeah.
it down, and this is 0.46. Okay.
Okay.
So the hemoglobin is 1/3 of that.
Oh,
If you're
okay.
gonna go rule of threes, and the correct answer a while ago was about 15.
Okay. Thank you.
You're welcome. Okay, got it. All right, any other questions? Thanks for asking.
Yeah, you kept mentioning something about an artifact. I didn't really understand what you're saying.
Artifact. That means that, okay, so if I drew your blood's gonna be normal. Now, there are conditions where you have what's called a cold agglutinin. You probably hear about that in either blood bank or immunology. On those conditions, it's an artifact. You can't turn out a CBC when in the presence of cold agglutinins. Cold agglutinins is caused by an antibody called anti-I. Okay, so anti-I will cause your RBCs to clump. So when the RBCs clump together or agglutinate, then when you run it through your analyzer, that clump of cells is going to run through the analyzer, and you're going to get a falsely elevated MCV into 150s and 160s. That's physically impossible for one red blood cell. Like I said, there's no such thing as a humongocyte, okay? That's what it's actually reading is a clump of cells that went through the flow cell, and it says your MCV is 150. Or there are conditions where platelets have a tendency to be naturally sticky in some patients. So when platelets stick together, they run through the flow cell, and that's going to give you a falsely elevated. It's falsely elevated because that's not what your true CBC is. It's a falsely elevated MCV. And the way you can tell that it's platelet clumping is that when you look at the CBC, if you have a CBC that shows, and I'll show you this in lecture 10, if you have an MCV that's also in the 150s, 160s, you can't automatically say, oh, that's cold agglutinins. But if you happen to glance down to the platelet count, and the platelet count is about 10 or 15, what's a normal value for platelets?
150 to 450.
Right, and if on your printout you get 10, okay, so where did all those platelets go? They went and got clumped together. So that's what happens. So there are things, those are artifacts, okay, that needs corrective action.
Okay, so artifacts is basically a situation where your CBC is inaccurate.
Correct. It's not reportable. You have to do something to correct that. Like,
Okay.
for example, for the cold agglutinins, the correction is pre-warming the sample. So what you do is you take your purple top and you put it in the heat block, and you put it in the heat block at 37 degrees for about half an hour. So what that does, it makes the tube at 37 degrees, okay? So if you have a normal purple top, it's been sitting around at room temperature, you run it, the anti-I is active at room temperature. But when you run it when the specimen is at 37 degrees, anti-I is inactive, okay? So there's no more anti-I antibody, your red cells are free, okay? So when you run a pre-warmed sample through the analyzer, your MCV is going to come down to normal, between 80 and 100, and now you have a perfectly good CBC. For the platelets, if you get platelet clumping, the remedy for that is to redraw the patient in citrate, because sodium citrate has an effect on platelets to prevents the platelets from clumping. So when you have platelet clumping, and you can tell platelet clumping when you look at the smears, you'll actually see platelet clumping. I'm going to try to get a collection of platelet clumps and have it in my collection so that you can see what platelet clumping looks like on the smear. But those platelets will clump, and like I said, in your specimen, it's going to run through the flow cell, and you'll get MCVs of 150 and 160. So you'll say, oh, okay, cold agglutinin. But wait a minute, I just noticed the glance down of the platelets that it's about 10, 15, or 20. That's critically low. That's a critical value. But if you have an MC, so that whole CBC is not reportable. But if you have that's critical value, it's a panic value where you should call. But then if you notice that your MCV is sky high abnormally, then nothing on that CBC is reportable. You have to find out what's going on. So what you do is you redraw the patient in a blue top tube, and the sodium citrate in the blue top tube will release the platelets from clumping, okay? And when you run it through the CBC, because of the anticoagulant blood ratio is a little higher than EDTA, you have to correct for the anticoagulant dilution. So what you do is you take your measured parameters, which is your whites, your reds, your hemoglobin, and your platelets, and multiply it by 1.1. Because if you run it through citrate, it's falsely diluted. So it needs to bump up by be multiplying by 1.1. And the correction is 10/9. the blood to anticoagulant ratio. Okay, so 10/9 is 1.1. So I already did the math for you. So that's what you do for platelet clumps. And then once you do, you'll have a normal MCV, and then you'll have a normal platelet count. And you're gonna say, oh wow, this is all normal. But it's normal because you took away the platelet clumping artifact. Okay, there's other things that'll cause artifacts, and not like I said, I'll go over that in lecture 10. Anybody?
One question. So basically, any artifact discovered is going to trigger a secondary kind of action by the technicians or somebody along the line?
Yeah, and it's up to you to detect those. It's up to you to detect those. Like, your CLS can say, okay, he's going to hand it to you, and he's going to say, he or she's going to say, well, can I report this? And you're going to look at it, and you're going to say, no, I can't report it, or looks good to me. Well, report it. Okay, so that's why you have to look at certain things to make sure that it's reportable or not. And I'll go over that in lecture 10. Okay, it's really important to know that. I mean, like I said, in platelet clumping, if you report out a platelet count of 10,000 or 20,000, you already told me that the normal value is much higher than that, then the doctor is going to panic, and he's going to call the blood bank. I need 10 units of platelets, the stat for this patient, because I have a critical value platelet count on a 10,000, but that's not real. What's causing that 10,000 is an artifact and some platelet clumping. That's why you need to look at the whole CBC and make sure it makes sense. If you just look at the platelet count and not notice what's going on with the CBC, with the MCV or the MCHC, then you can falsely report a critical value that is not real. All right, so I'm going to throw you a whole bunch of CBCs, and you're going to tell me, is this reportable or not? And if not, what's going on? Okay, because you can have disease states, like you can have disease states where super low H&H, super low platelet count, normal MCHC, everything looks low MCV. You can say, well, it's a low MCV, but the MCHC is good. So what's going on here? I think this is real. I think it's reportable. You're going to have to make that decision, and I'll teach that to you, and that'll all be in lecture 10. Any more questions?
Yeah, what's going to be on the quiz tomorrow?
Let me see, 24 hours and less than 24 hours from now, you'll find out. It's not going to be that hard. Like I said, it's baseball season. I don't think I'll throw you any curveballs, but I will throw you curveballs this semester. But it's going to be straightforward.
Like normal values.
Normal values for sure.
Calculations.
Yeah, normal values, definitely normal values. Make sure you know where you put your L's and your H's. Okay. What happens in a CBC, the reagents, what's measured, just kind of like the homework. Focus on the homework, focus on the PowerPoints. Okay. You have your homework, and you have your, what to look for. I mean, what's wrong with the CBC kind of thing. All right. So at this point, you should only know rule of threes. You're not trained to look at the MCHC yet. I think I'm reserving that, but I will eventually throw those things at you. Make sure you can recognize rule of threes. Know what the CBC is, the automated absolute counts, things like that. It's pretty basic. I mean, lectures 1 and 2 are pretty basic, pretty fundamental. Your homework is a pretty good representation, and the PowerPoint's not too long, not too detailed. I really try to keep track of whether or not you're able to follow with the way you're responding and the way you're answering questions. You guys are asking the right questions. So, but you guys are doing okay. Should do fine tomorrow. So the way it'll happen is Xavier's going to print the quizzes. He's going to give it to you at 5:30, and then you'll have what you'll finish. It shouldn't take you more than half an hour to do both quizzes, and you guys will give it back to him, and I'll pick it up on Friday, soon by the school, and then I'll correct it. All right. Any other questions?
For corrected WBC, so we would have to know the formula.
The formula for the RBC indices? No, that was given today. It's not fair for me to give you the formula for the MCB and the MCH, etc. It's not, that's not the RBC indices will not be on the quiz tomorrow, and I'll double check that. But next week it will.
Okay.
Next week it will. Any other questions?
Question. About the quiz, how many questions are there?
It's 2 quizzes. It's almost like it's not that long. It's not going to be too long. It's not going to be like 10 pages. Don't be intimidated by the size. It's not going to be too long. Probably a couple pages for each quiz. It's like a homework assignment, but not open book. Put it that way. Well, you guys are worried about the quiz tomorrow, huh? Believe me, it's not going to be that bad. But make sure you know your normal values. Okay. Make sure you know where to. Okay, there was one class where I gave this quiz, and the students bombed on the normal values. So this was quiz 2. I had to give a quiz 2A. Okay, put it that way. I had to give a quiz 2A to make sure that they knew their normal values. I'm anticipating I'm not going to give a quiz 2A for you guys. All right. If I have to give a quiz 2A, I'm going to be incredibly disappointed, but I think you guys should know it. All right. Any other questions? Last minute questions before I'm gone before next Wednesday?
There.
Going once. Going twice. All right, good luck on your quiz tomorrow.
Thanks.
Oh, did you guys use up a lot of glass last week?
Yes.
Who went through a whole box?
I
Nope,
did.
you went,
Yeah.
really, a whole box?
Yeah.
Yeah.
For the slides?
Yeah.
Yeah. I
Oh,
think
yeah.
probably wasn't a whole box
Oh,
for me.
yeah.
I should have warned Daniela. I mean, at least two box was, I hope Xavier was really strict because I told him no streaks at all. And
Oh, he was
Oh, he was strict.
Yeah. He rejected them.
he
He
did
wanted
a lot of rejects. I said,
Yeah.
oh my God, you mean that little blip there is? And I said, no, it's got to be for me. When I taught the lab, it's like, it's got to be good enough that I have to read it. Okay, if I see a little streak there, nope, do it again. So I'm glad he was strict, and I'm glad to hear that you went through your inventory of glass slides. Good for you. A lot of clang, clang, clang. All right. Guys threw away a lot of glass last week. All right, good to know. Okay. There are no other questions. Like I said, good luck on your quiz tomorrow. If I find something that I think I may have overlooked, I'll look at the quiz again. Then I'll shoot you guys an email. Make sure, like I'll say, make sure you know this. Make sure I won't tell you what the question is, but I'll make sure that I'll steer you in the right direction. Okay. One other thing is, when your exams are. Okay, from the exam schedule, right? I gave you the lecture schedule, and then I gave you the quiz and exam schedule.
Yes.
If for instance, your exam conflicts with another exam, like in chemistry or whatever, serology, I'm pretty lenient. In what I mean is, I'll adjust if you want me to adjust, so that you don't have 2 major exams on the same day. Okay, so if you encounter that situation, let me know, because there's still some leeway, even though I'm not giving the exams in lecture. I have enough lecture time, or there's enough lab time where I can switch it over to a different day. So if you find yourself taking two major exams on the same day, and you say, well, can we take it on a different day so that we're not overloaded, just let me know. I don't know what Miss Myrna's schedule is on her exam schedule. She's actually in the same situation as me, because her subject is the other major subject. The two major subjects this semester are hematology and clinical chemistry. So, and this is the first, and usually hematology is 2 lectures a week and chemistry is 2 lectures a week. Well, Dina made it 1 lecture day per week. So, which means that I have to do 2 lectures for each meeting. So when I do 2 lectures for each meeting, it leaves me less time to give the quizzes and exams. So that's why you're taking your quizzes, exams during the lab. Okay, but let me know if you encounter a situation where Myrna says, we're going to have a quiz, an exam in 2 weeks. Well, it looks like you're going to have an exam in 2 weeks too. Just let me know if you want it earlier or later. All right, if you come
Okay.
across that situation, and then we'll work something out. Okay. All right. If you have no more questions, like I said, good luck on your quiz tomorrow. You'll all do fine.
Thank you.
Oh,
All right.
Professor,
Yes.
in addition to like the list of exams that we had, I don't know if Miss B has her list of exams, but most of our exams for this class is on the same day as our exams for a year analysis class.
Your analysis, really? So what are you
Yeah.
saying? What would you like to do?
Oh, I don't know. I just wanted to put that up or let everyone know that that's what the situation is right now.
Okay, so with the material that I'm giving you, it's a lot of material so far. You're going to be taking your first quiz tomorrow. So depending on how you're studying and depending on how much and how you pick up during the lectures, and if you're doing fine, you may not need to change. Your analysis is, who's teaching it? Is that Milton? Or is that Carlos? Who's teaching that, your analysis? I don't know what their exams are like. If they're kind of, are they major like mine? So I don't know what the quizzes and exams are like. If they're major, meaning that they're long exams. Why don't we wait and see it until after the first exam, and then you can get a feeling for, wow, that covered a lot. That was a lot of information. Maybe I might want to consider asking for a change in date. Why don't we wait until the first one? Is that okay? Okay, because I know chemistry is a lot of information. It's a ton of information. And if you think that's a lot of information, wait till I teach you guys micro next semester in the spring. During that time, lectures will be face-to-face and the labs will be face-to-face. So I'll see you in both lecture and lab. Okay, but your major exam, I think, is going to be in a couple weeks. And then hopefully you can gauge to see how your year analysis exam is going to be, to see if we want to make adjustment. I don't want to make adjustments too early yet. Let's wait until after the first one, okay? Because you're going to have a total of 6 exams in this class. And like I said, the reason why you're having 6 exams, it's better than having 3 or 2, because if I give you 3 or 2, it's going to be comprehensive, but the topics are going to be diluted. The more exams I give you, then actually the actual exams are going to be more comprehensive. I get to ask more questions on more focused material. You see what I'm saying? Okay, if I gave you three exams, then the material is going to be diluted, and I won't be able to ask you questions on material that I'd like to ask you. Okay, Anybody? Last round. Okay, if not, like I said, for the third time, good luck on your quiz tomorrow. And I'll see you next Wednesday. All right.
Thank you.
Have a good
All
night.
right. Thanks. See you later.